Welcome and thank you everyone for joining and for supporting BIADE's webinar series. We are sponsored by Highmark, and I'd like to thank Highmark for being such a wonderful sponsor. I would also like to thank Dr. Cheng. Dr. Cheng will be speaking today on the art of Physiatry. So I want to say that if you are just joining us, first of all, welcome. And we will be recording this series, and we will be happy to answer any questions that you may have. This series will be posted on BIADE's website, www.biade.org, where you can go and watch the recording, share it with your friends, with your colleagues, with your support group. Just please share it and invite participants to join in the series. And I just want to welcome you. My name is Zawaya McElrath. I am the Executive Assistant for BIADE. We are honored to have a special presentation by Dr. Cheng, who will be speaking shortly. Dr. Cheng is a board certified physiatrist in physical medicine and rehabilitation. He represents Christiana Care. He is a BIADE board member. He joined the board in September of 2022. And I have a few board members who are on the call supporting the webinar series as well. And I also want to say that we have an upcoming June webinar that will be Tuesday, June 20th. So please join that as well. So we're going to go ahead, and I am going to stop sharing my screen, and I am going to turn this over to Dr. Cheng.
All right. How's that look?
It's perfect.
Good. Thank you. Well, thank you, Zawaya, and thank you, BIADE and Highmark for the privilege to be here today to speak to everyone about the role of physiatry in traumatic brain injury care. My name is Dr. John Cheng. I'm part of Christiana Care Health System. I'm the medical director of the Inpatient Rehabilitation Unit here at Wilmington Hospital. I'm speaking to you from my office, so from Wilmington Hospital here. But thank you for your time. Thank you for joining us, and I hope you find this talk helpful and interesting. All right, so to start out, what is physiatry? You know, this word is not a common word. It's not something we hear on a regular basis. You know, I've been doing this for about 10 years now. My dad still doesn't really know what physiatry is, so this would have been a useful talk for him. But anyway, an intro to physiatry. What is it? So my specialty can be called a number of different things, and so in general, the specialty is physical medicine and rehabilitation, or PM&R. We also can be known as rehabilitation medicine, or as the title of the talk, physiatry. So as someone who practices PM&R, I am a physiatrist, just as a cardiologist practices cardiology. To become a physiatrist, there's some steps to go through. So you have to complete undergraduate training, and then medical school, either an MD or DO, so a allopathic or an osteopathic medical program. And then after that, there is postgraduate training. And so this is the residency program. So most residency programs are 4 years long and involve an intern year, which can be a year of medicine, it could be a year of surgery, or a transitional year, which in some cases combines a little bit of both. But after that, once you've finished your 4-year residency, then you can practice as a physiatrist. Here on this slide where it says extras, that is referring to fellowships. And so there's different subspecialty training that some physiatrists elect to go into. Some of these subspecialties include traumatic brain injury rehab, spinal cord injury rehab, pain management, cancer rehabilitation, pediatrics. The majority of them are 1 year. The pediatric rehabilitation fellowship is 2 years. But in general, what do physiatrists do? So we treat multiple medical illnesses, disabilities that involve the neuro and musculoskeletal system. Our outlook and goals for patients are different as well. While you may have heard me say this at the last talk, but one of the adages that PM&R loves to say is that while some other specialties may focus more on adding years to life, PM&R focuses on adding life to years. And to kind of make that a little more succinct, we really focus on maximizing function and quality of life. This is really what we focus on. And so, for a lot of patients, truly quality of life hinges upon how much each one can function, right? How much each person can do for themselves. And so where might you see a physiatrist? And so pictured on this slide are three different scenarios, three different areas of practice. One of them is the outpatient setting or the clinic where you go, see your physiatrist for whatever issue it is that you're having, and we would see you in the office. Also on the inpatient side, like I said, here I am on our inpatient rehabilitation unit here. So if you are in the hospital for whatever, an accident or a stroke or any, whatever gets you hospitalized, and you're not able to discharge safely home, oftentimes the next stop might be an acute rehabilitation unit. And so if you would be admitted here, the physiatrist, either me or one of my partners, would be your main doctor in the hospital here, handling all your medical issues as well as your rehabilitation care. The last picture on this slide is in the consult setting. And so we are asked frequently by other specialists to consult on their patients, to add whatever we can add to help answer certain questions and guide certain treatments in the right scenario. Christiana has a very robust trauma department, and there are a lot of traumatic brain injuries who come through Christiana, and we are consulted on a lot of them. So you may see a physiatrist in any one of these different domains. And so this is kind of how I'll structure this talk, and going through each of these areas and explaining how we can benefit and what our role is there. All right, a little bit about me. So I am a board certified physical medicine rehabilitation physician. Like I said, I'm the inpatient medical director here at Wilmington on the rehabilitation unit. We're on 6 West here. Prior to COVID, really, I was seeing more outpatients and kind of rotating through, very involved in the amputee clinic, also seeing patients transitioning from AI DuPont Hospital for Children as part of the Center for Special Needs here. And that was a great experience. That was something that we really needed in the community. But now, since COVID, I've really been spending the vast majority of my time here on the rehab unit. I will see some outpatients periodically, mostly patients with spasticity or tone issues. And so I see the majority of the backlift and pump patients here in the Christiana system. I do Botox on patients, and some joint injections. And there are certain traumatic brain injury or spinal cord injury patients who I still follow, but those are less common. I love cats. These are our cats here. There's Oliver on the left here, crossing his legs there, and in the middle is Hazy wearing a sock hat, and Cloudy is on the right, looking very dapper in the sun. All right, so what is the point of this talk? It's not so much to talk about my cats, although I would do that. But anyways, to talk about what physiatry does, right? What is our role in these different settings? Where might you encounter a physiatrist? Where might you benefit from seeing a physiatrist? And to highlight some important aspects of the care for TBI patients as we go through. And then if you have a physiatrist, how to really get the most out of that visit. What can we do for you, and how can you really maximize your what you get out of the visit. All right, so we've arranged this in a few cases here. So the first case, patient AB, 23-year-old young man. He sustained a severe TBI after a car accident approximately a week ago. And so, important information about him is that his GCS, or his Glasgow coma score in the field, so at the place of the accident, was 5, so quite low. Because of that, he was not protecting his airway, and so he required intubation. He needed a breathing tube placed by the paramedics. When I see him here, he is on a ventilator. He's not responding to commands. That he needs to be sedated by the ICU team in order to not pull at his lines and pull at his airway. His family's in the room. They want to know what to expect. They want to know how to plan. How can, what is the long-term outcome going to be, and what do we need to do? And so they consult physiatry. This is where we can come in handy. And so in the acute setting, so this is in the hospital, this is in the ICU, there's an ICU team who is taking care of this patient. And so they're focusing on all these different things, the breathing, the blood pressure, making sure that, there are no seizures, no infections, so on and so forth. They're in this setting, they're handling all these medical issues. Where does physiatry come in? So when we see a patient, our focus, yes, is on the patient's current situation, but we need to know more about their history in order to determine or help prognosticate about what's going to happen going forward. And so when we see the patient and gather the history from the family or from the medical record, we need to classify the severity of the brain injury. Is it mild? Is it moderate? Is it severe? In this case, certainly this patient has had a severe brain injury, as we can see in his clinical case and also from his Glasgow coma score. We need to monitor the patient as we go. Physiatry is really not a static field. The name itself, has is related to movement, but also as we're following patients, really we have to see what changes with time, because that can determine what will happen and also what we do for the patient. So we need to monitor for emergence. And this is where, we're looking for certain criteria in terms of orientation, command following, spontaneous movement, so on and so forth, to see how, where a patient is in terms of their progression through traumatic brain injury. Along the same lines, there are other injuries that happen as well. And so, there are many cases where there are concurrent traumatic brain injury and spinal cord injury or orthopedic injuries. And so factoring these other injuries in is very important when we're considering prognosis as well as rehabilitation course. It's always important to know what the patient was like prior to the injury. If there's any pre-existing problem, if there was any psychological illness, if there were other comorbidities or other medical problems that were causing issues beforehand, we need to know those things, because those can absolutely help us figure out what the patient will look like as they progress. And discharge planning, and this is often why rehabilitation is consulted. And when we say discharge planning, we mean after this area of the hospital. And so if the patient, the usual pathway is from the ICU to maybe a step down unit to a regular quote regular floor bed. But then what happens next? How does that patient go from hospital to home or hospital to where? And so that's where rehab is can be very helpful, because we give those recommendations. Part of the recommendations come from synthesizing a lot of different information. And so some of it is the medical piece that's critical, but also the functional aspects are just as important. And so that's where we team up with our therapy coworkers to really piece it together. And so, looking at what a patient can do in the hospital in the context of what they were doing before, and also with the view of what they need to do at home in order to get there. And so if the situation and their progress is not to a point where the patient could be safely discharged home, that's when we consider other discharge destinations, such as an acute rehabilitation unit or subacute rehab. And education is so critical. And so this is, educating the patient, educating the caregivers, educating the family, educating the medical team. There's a lot here that we need to, teach. And so part of that is because we see the patients for a longer period of time. In the ICU, there's a very specific goal, and that's to, of course, to sustain life and to get the patient stable. But we follow these patients for years often, and so we have a different perspective about where a patient is going and what to expect. And so providing the education for all members of the team and also the families is so critical. And there are also, of course, there are what we call acute measures, in the ICU as well that we can consult on, such as spasticity management, sometimes ventilator management, although that's a little bit less, and skin protection and bracing and different things. So one thing I'll just touch on very briefly is the Rancho-Los Amigos score. So when I talk about a patient progressing through the traumatic brain injury recovery process, this is what I'm talking about. And so, the most severe level of brain injury or most depressed amount of spontaneous activity would be a level 1 Rancho-Los Amigos score, and progressing all the way through to level 10. And so at level 10, we can consider that almost a full recovery at that point. That patient is what's called modified independent, meaning they can do everything on their own. They may need assistive devices or adaptive strategies, but they are not relying upon others to do their normal ADLs or their activities of daily living or function. And so as we go through this process, it is very, there are certain landmark areas that are so important. And one thing just briefly to touch on is the difference between Rancho 3 and 4 and 4 and 5. And so what we see here that's so important in Rancho 4 is that a patient is confused, is agitated, right? That's what we're looking for. And so a lot of times, a patient may be in the ICU, they're sedated, they're calm, everything seems, settled in. But then they start becoming agitated. They start pulling at things. They need restraints, maybe even swinging at or grabbing providers. We say, this is a bad thing. Well, not necessarily. What it could represent is that the patient is emerging from this deeper traumatic brain injury and progressing or emerging from the deeper coma that they were in to now be in a state where they are agitated, but it is a sign of recovery. And then what we look for then, of course, is for that period to pass. And so, that length of time varies from person to person, but that's a very important landmark there, the Rancho 4. So some pearls. So what do we talk about? What do we consider? And so, as I said before, the grading of the degree of severity, so mild versus moderate versus severe. And there are a lot of different criteria. I won't go into that right now, but considering unconsciousness and GCS scores and different things. But that matters because the degree of severity can help prognosticate recovery and give a general idea of how things might end up down the line. And unfortunately, there are even mortality rates based on the degree of injury. And so that is important, of course, for the family and for the team to know. And then considering different prognostic factors that we get from the history and get from the clinical examination that can help us, educate on how things might turn out. The Rancho scale, we were just talking about that. And then, really as part of discharge planning, it's so important to start thinking about caregiving early on, right? whenever I admit a patient to my rehabilitation unit here, I always ask about the home situation, ask if there are any family or friends available to assist. A lot of times patients say, hey, I have some siblings, but I'm not going to need them. And I say, that's fine. That's good. I certainly hope not. But I always want to know. I want to know what the maximum amount of assistance, the best, home setup you can have in order to plan for it. Because if we don't need it, great, we don't need it. But if we do, we need to know. And so to plan ahead is very important. There are different things both in the hospital and after that families can do to help their loved ones. And so these are part of the education pieces that we give, during the consult stage when we're seeing that patient in the ICU or on the medical floor. And again, more education piece, timeline for recovery, and then the discharge destinations. All right. And so just, some brief takeaways. It's never too early for a PM&R consult. When I was training at Jefferson, we would be consulted on spinal cord injury patients when they're still in the emergency room. And so, that's a very different time frame than when we would see them, admit them on our acute inpatient rehabilitation unit. But it's critical at that point too, is to see what their severity of injury, what their exam is like in that early stage. It's never too early. There's always something for us to add. Again, we can help in short-term, medium-term, and also long-term planning and care. And so we may not follow the patient for throughout that whole spectrum, but there are considerations and different recommendations we can make all the way throughout. And then I hope I've stressed it enough, but education, expectations are key, right? These are so important. And so, we always want to instill hope, but we need to be realistic at all times. And so that's kind of the tightrope that PM&R needs to walk. And so when we're talking to families and patients and caregivers to always consider these things, that we want realistic expectations, but there's, you can never put a limit on how much someone can recover because everybody is different. All right. The next case. So this situation, this scenario is on an inpatient rehab unit. So this patient is a 47-year-old female, had a severe TBI after a fall a few weeks ago. She went through the acute care hospital, all your regular hospital stay, and then was discharged and admitted to an acute inpatient rehabilitation unit. And so now, I am the physiatrist. I'm taking care of her. She's now my patient. I'm her main doctor here. So she was more agitated when she got here than she was on the other unit, or at least what they were telling us, which is often the case, unfortunately. Her family is very concerned. They're worried about the confusion, agitation. Her husband said, maybe I should have just taken her home. Right now, she's in another hospital. She doesn't like it here. Maybe this is the wrong place. And so what do we do in this setting? And so, again, very team-based approach. And so on the rehab unit here, the physiatrist or the doctor works very closely with therapy and nursing. And so it's, you can't have, one without the other. These are all critical members of the inpatient rehab team. And so on the therapy and nursing side, in the case of this specific patient, there are many environmental things that we can adjust and optimize for this patient. It's always key to have low stimulation for most patients, but really for traumatic brain injury patients, especially upon initial transition from one hospital to the next. A new environment can be very disorienting. And if you're disoriented, that's a recipe for confusion and for agitation. I skipped over it, but I shouldn't have. So safety is really truly number one. I mean, this is our job here, is to keep patients safe both here and plan and prepare for a safe discharge from our unit, hopefully home. And so safety is really paramount in all our considerations. Close observation. When we admit a patient, we place them in certain areas based on their level of injury and cognitive status. If a patient needs to be watched more closely, then we put them in certain areas to be within line of sight from the nursing station. But these are different things that therapy and nursing really factor in on the unit. And of course, frequent reorientation, reminding the patient of the date, where they are, writing it on the board, turning the lights on in the day, turning them off, turning the TV off at night, making sure it's a good environment for the patient. And these are all of these things we're seeing here are performed by other team members, but a lot of them are guided by the physiatrist or the rehab doctor who leads the team. And so on the rehab doctor specific side, what we do, of course, a thorough exam, we're doing the Rancho scoring. We're determining the severity of injury at that point in time, which again helps us to prognosticate. We have to set the right expectations and to know, at least have an idea of how that patient is going to progress while they're on our rehab unit, because that will help determine where they can go after and how much care they're going to require. And so, that is throughout the course of the patient's stay, but also, with this newly agitated patient, it's not always just environmental. It's not always just because they've gone from one hospital to the next. I mean, there may be other reasons, certainly, for agitation. And so, we put on our medical hat and we're doing, getting labs, we get different imaging, review medications, adjust those medications if we need to. And then again, the education and counseling piece. But at the end of the day, the rehab doctor is the leader of the team on the rehab unit. And so we're guiding all of these, all these aspects of care. And so, like I was just saying that, when we're thinking about an agitated patient, why is this patient more agitated? It could be something simple. It could be, maybe this bed is more uncomfortable and they're not used to it. They don't like it. And so we have to factor all these things. But there could be more sinister, something brewing inside that we need to figure out. Sometimes it is emergence from that level of Rancho score. And so they're progressing in their recovery. And so to be able to identify that and to educate the family and caregivers that there's not actually anything wrong here, that this patient is getting better, is critical information. And so, TBI recovery is a process, right? This is a very important thing to consider on the rehab unit, and each patient has their own speed. And so, the questions we always get asked is, how long is this going to take? How long am I going to be here? When can I go home? I can give you an average length of stay, but the time you will be here varies. It totally depends on how your recovery goes. And at the end of the day, the goal is the same for every patient, is safety at home. And then so that ties in with setting the expectations. And one thing that I found very frustrating to families is when they're told, oh, my father will be on the rehab unit for a month. That's what they told me in acute care. But then, they get better and they're discharged in 2 weeks, right? And so, this is oftentimes a point of contention. But setting those expectations early, and that often starts even on the consult side from that previous case we were talking about, is important. But I would say, we're wrong a lot of times, this because we don't have crystal balls, right? We're projecting, we're making educated guesses on how a patient will progress and how much time they'll need. But I think being able to ballpark things and give a general idea can be helpful for patients and families. The way I practice is less is more, and I think that is I think that really applies in the acute rehab setting. We don't always have to chase problems with medications. We don't always have to add to what we call polypharmacy, so many different medications, so many different things. Sometimes allowing some time to relax and to settle in can be just as good as an Ativan or a Xanax. But one thing, in particular, applying to TBI patients is, if a patient's agitated, sometimes you just need to let that patient just let them breathe, let them calm down on their own. And that's what they need, instead of escalating the situation and potentially, making it worse or creating something physical or confrontational. And then discharge planning. I always say discharge planning starts even before the patient's admitted. We need to know all this information prior to them coming, so we can, number one, determine if this is the right place for them, but also to help prepare for what's after acute rehab. We always have to think about what the next step is. And so some takeaways. Environment, so important, right? Because there are, simple changes there. If we don't need to give more medications, do any bracing, whatever these different things, just by changing the environment, that is a win, right? And that's something we need to think about. We need to think outside of the box a little bit. And so that, is takeaway number 2, is that TBI management is not always straightforward. It's hard when you can't always get a very clear history from the patient, of course, no fault of theirs, but so it requires some creativity, requires some thought to figure out how to best take care of this patient and their family. And I tell our team here all the time, always be discharging. And so this is really needs to be our thought from, like I said, from before the patient gets here, but at least, when they hit our doors, we need to always think about what can we do? What do we need to do to fully prepare this patient and their family to optimize, create an optimally safe discharge home. That is, it always needs to be on our mind. Always think about what will the next steps be. All right, case number 3. So this patient, 55-year-old lady, had an intracranial hemorrhage, had a bleed in her brain in 2021. And then she went to a subacute rehabilitation facility. So not an acute rehab like we have here at Wilmington, but this is like your Acadia, your Manor Care, that type of facility. She now comes to clinics. Now we're seeing her in the outpatient setting with weakness on her right side and very painful muscle spasms. She tells me she's having trouble sleeping because her right leg folds up on her at nighttime and doesn't let her sleep. And then her husband's there is asking about, are there any braces? Are there any, devices? We've seen others who have these fancy things on their ankles, which help them walk. How about for my wife? And so, when I see a patient in the clinic, there are a lot of questions to ask. I'll spare you all those questions, but in general, we need a thorough history and physical examination, right? And so I don't know if anyone here has seen a physiatrist, but I hope that you've had the most thorough neurological and musculoskeletal exam of your life given to you by this doctor, because that's really what we base everything we do on. And so, we start there, very thorough history, very thorough physical exam. We have to get the overall picture. How are you functioning on a daily basis? What are you doing at home? And what comes out of that is, what would you like to do at home? What is there that you haven't been able to do to a satisfactory amount at home that you want to do? How can I help you get there? And then specific issues. Are you in pain? Are you having any of that muscle tone, any of the abnormal muscle movements that you're not telling your limbs to do? Are you having any incontinence or any constipation or urinary retention issues? These are so common in TBI and in other neurological issues. And then, like the husband was asking, do we need braces? Do we need a different assistive device? Do we need to tweak that cane or change that walker? And then there are plenty of other issues that we consider on in the clinic as well, in the outpatient setting. So general medical issues, certainly depression is so common after devastating injuries. And then preventive care. I always say the best rehabilitation is prevention. And so you may see me going around the hospital, looking for spills on the floor, wiping things up, and taking things off the stairs, because if that patient, or that person doesn't fall, then we don't need to rehab them, which is, ideal. May mean I don't have a job forever, but at least anyway, that patient is saved a lot of suffering. We also do procedures in the office, like I said before. So I manage backlift and pumps, and so I do those refills and managements and management multiple times a week for patients, and then Botox injections and different joint injections. And like I said at the beginning, there are different fellowships that one can do. And so you may have seen, if someone has had chronic back pain, radiculopathy, pain shooting down your leg or your arm, you may have gotten an injection in the spine by a physiatrist. This is something that some of us do. And we're not primary care doctors, but there is a major role in referrals and in integrating the team. And so on the inpatient rehab unit, the physiatrist, the rehab doctor, is the leader of the team, but also in a lot of ways, in the outpatient setting, we're also leading a team. And so referring to psychology, neuropsychology, or to different therapies are part of what we do all the time. And then also coordinating referrals to surgeons or different specialists as well. We do that on a regular basis. So what are some pearls in the outpatient setting? So just like in the consult side, on the acute rehab side, but function and quality of life, these are paramount. These are really what we're doing here, right? So we want to maximize function in order to increase quality of life, right? This is what our focus is. This is what our goals are. And so how do we get there? We target our interventions to specific needs. I always talk to patients about spasticity management. And I say, we don't necessarily need to treat the spasticity. If it's not causing pain, if it's not making your ADLs more challenging or getting dressed difficult, if it's not causing difficulty staying in your chair or in your bed, or causing problems with sleep or skin, or preventing you from doing anything that you want to do, then we don't necessarily have to treat this, because every treatment, every intervention really does have a side effect. There's no way around that. And so, my goal is really to limit over treatment, because sometimes they're cause more harm than good. And so we really need to target our interventions to very specific needs of the patient. And then preventative care, always have to keep that in mind. Why are we doing something? I might be bracing the patient to maintain range of motion, so to prevent a contracture in the future, because once that joint is fixed in a certain range, is very hard to get out. And then sometimes we treat spasticity to prevent skin breakdown, these different types of things, or I may fit a patient with a brace to prevent them from tripping, potentially causing a fall, and maybe an orthopedic injury or something else, right? And so preventative care is so key, and that also factors in with the other medical piece. Maybe a patient needs to be on a blood thinner, or on aspirin, or on a statin to prevent some other cardiovascular or other issue down the line. Regarding bracing, I always say the best brace is the one the patient will wear. Sometimes we have all these ideas in our head as the doctor that XYZ braces would be best for this patient. But if it's just a decoration on the shelf or, in the back of a closet, it doesn't help anybody, right? And so the situation sometimes isn't always optimal. Maybe that's not the best brace for the patient, but if they're wearing it, then, and it's not causing trouble, then I'll take it, right? And then what I was talking about before, that not all tone needs to be treated or reduced, right? And so this is just a few pearls in this setting, and some of the things that I consider when I'm treating my patients. And so to me, the biggest takeaway, and this, again, kind of a general idea that really applies to every situation, is to listen, right? I find that listening is at somewhat of a premium nowadays in medicine, given that there's so many pressures, time pressures, and you have to see so many, X number of patients in ever shortened times. And so, it's getting harder and harder to listen, but there's no substitute for it, right? And there's no replacement. That every treatment, every plan, everything we do really needs to be patient and family centered. And that starts by listening, to hear the concerns, to hear what their goals are. If a patient's goal or a family's goal is not my goal, they're not the ones who's wrong. It's me, right? I need to listen to the patient and the family and tailor what we do to achieve their goals. When we're on the same page, when we have the same understanding, that's when we can have successful treatment. Otherwise, it's me, recommending a lot of things that may not get done because they're not in line with what a patient or their family wants. And so, there's a lot of compromise when it comes to physiatry and PM&R. When we're treating patients, we really have to, consider that the human being in front of us is the one that we need to treat, and not just follow, the textbooks that we studied when we were, in our training. Because ultimately, it's that pathway that will lead to optimization of quality of life, right? That's what's going to maximize a patient's quality of life, because it's so subjective, right? Quality of life to one person or to me is not the same as to everyone, right? And then also to consider that we're in it for the long haul, right? So physiatry is one of these things where, a lot of the issues we treat are chronic issues, right? So a TBI, osteoarthritis, spinal cord injury, spasticity, all these things, these are often chronic problems, and it's not just a one-time treatment and then that's it, or one medication and you're good to go. But these are patients who will develop relationships with and see for years. And so I consider that a very special part of my job, because we get to really stick with people and get to know them and learn about them and their families, and also, to be able to take care of someone for a long time. It's really, really kind of a special thing. So how can you be seen? So this slide is just, a few different ways to be seen by a physiatrist. If you have any of the needs that I've touched on, and even, some that I haven't. I mean, this has not been comprehensive, but in the Christiana care system, I didn't list myself here just because, again, the majority of my time is taken up on the rehabilitation unit here. But two of my partners are seeing outpatients on a daily basis. And Dr. Margaret Guest is here, and Emily Panhouse. She's a physician assistant. They see outpatients every day. And so this is the Wilmington address, but they also have clinic on Concord Pike in Glen Mills, and then in at what we call HCCC, across the street from the main Christiana Hospital in Newark. But that is the scheduling number. So 302-623-3050. That's the way to get scheduled to be seen by a physiatrist. So if you think you have one of these, these needs and could benefit from being seen by PM&R, that's the number to call. But also, Dr. Haresh Sampath Kumar, he's one of our BIADE board members as well. And so this is his company, Delaware Neuro Rehab. And so his practice is outpatient, and they have integrated therapies, physical therapy, occupational therapy, and speech therapy, also psychology and neuropsychology. So it's a very comprehensive practice. And so I've listed one of his addresses here. He also has a Wilmington address, but this is the Dover address and phone number. So feel free to reach out to his clinic as well to be seen. And if you have a pediatric patient, so someone under the age 18 or under, I think 18 is included, but don't quote me. Then on here is one of the physiatrists, Dr. Eileen Shea. So she is an extraordinary pediatric rehabilitation physician, but there are others as well at the AI DuPont Hospital for Children who see rehabilitation patients. And so that's the contact information for them there. And that is what I have. Thank you very much. I appreciate your time. If anyone has any questions, I'm open to answering.
Thank you so much, Dr. Chen. That was excellent. You were so thorough. I didn't understand what physiatry was. I didn't know what it was. I did a little Googling, but your presentation helped me a lot. So thank you very much.
Thank you. You're welcome. Yeah, it's very broad, right? There's a piece of orthopedics, medicine, neurology, rheumatology, all rolled into one. And so it's a little bit hard to describe sometimes, but we're here for you. We're here for the patients.
Thank you. And as I stated before, I would like to let everyone know that I will be posting this recording on BIADE's website. I also will upload it to the YouTube channel that we have. The Brain Injury Association of Delaware has a YouTube channel, and I will upload it there as well as putting it on the website. I do have a question. The question is, how involved do you get in the rehabilitation while patients are in the hospital? Do you see patients who are in for mental issues who are also a TBI survivor? And that question is from D. Rivard.
Yeah, that's a great question, D. So that would be, what you're describing is in the consult setting, right? And so if a patient, can be in all sorts of different places in the hospital, if they're, on a regular medical floor, if they're even on the, even on the psychiatric unit or wherever they are, right? If that provider, if the doctor responsible for the patient on that unit consults us, and then we would get involved in the care there. And so, one thing that we're piloting a little bit at Christiana is we're trying to, increase our presence throughout the hospital. And so, just like, it was hard for Zawai, to know what physiatry is, a lot of the providers, a lot of the doctors in really, you pick any hospital, are struggle with the same thing, like don't know what physiatry is, what we can bring. And so part of what we need, on our side, what we need to do really as a field is to increase awareness of what physiatry is and what we can do. And so I'm really happy for this talk, but that can increase the number of consults we get and our involvement in the care in different areas of the hospital. And we see plenty of patients who are not new or acute traumatic brain injuries, or other things, spinal cord, whatever. So we get patients who've had injuries years ago and are dealing with sequelae. I mean, my last talk was on post-concussion syndrome, but right, that could be years later, right? And so same thing with TBI, right? Certainly these lasting injuries that are years out, we certainly see patients in the hospital as well who've had these problems.
Thank you, Dr. Chan. Dee also said, I am going to let my sister-in-law know about you, as she is usually treated at Christiana Care for her brain injury when she needs to come in.
Okay. Yeah, great. Yeah, please do. Please do. Yeah, we in an ideal world, all the traumatic brain injury patients would have a physiatrist, right? Every spinal cord injured patient would have a physiatrist. There aren't enough of us. I wish there were more, but absolutely, right? Yeah, please refer her over. It'd be good to establish care.
Thank you once again, Dr. Chen. Do we have any other questions before we close out today? Cheryl, would you like to say something? Would we like to hear from our executive director? I think not. Okay. So I do want to thank everyone once again for joining the 2023 Educate Delaware webinar series that is sponsored by Highmark. I would like to also thank Dr. Chen. Thank you for the participants. This has been a wonderful presentation, and I definitely learned a lot. And it was important that you said that every person that has a brain injury survivor or a spinal injury needs a physiatrist. That I think that's the wealth of information that needs to be shared with the world, that no one really talks about that,
Agreed.
or that they know. So thank you for that and for sharing that. I will be posting. I want to also apologize. I said that you can put your name in the chat. The chat is disabled because this was a webinar. So I do apologize for that. Cheryl has come off the camera. I think she wants to speak now.
Hi, I'm so sorry. I was trying to figure out how to come off mute and turn my camera on. So Dr. Cheng, thank you so much. Very, very informative. We appreciate your support. This was just a wealth of information. So thank you so much. And I know, and I'm sure is why I shared with you that many of our constituents like to kind of view it in their own time. So I think this will continue to be viewed over and over again. And the information you shared is so important.
Great. Yeah. Thank you for having me. I appreciate the opportunity. Thank you.
Yes. Thank you.
Okay, so thank you everyone for joining, and please check out the website, share the link. I will be sending it out for the participants on the call so that you can share it with your colleagues, your constituents, your network. And please join us on Tuesday, June 20th for Dr. Terry Harrison Goldman from Nemours Children's Health will be presenting Bridging the Gaps in Mental Health and Brain Injury. So thank you, everyone.
Thanks. Bye-bye.
Thank you.
Bye.